So good morning again, everyone, and thanks for the opportunity to present these research findings. I'm going to share in this presentation some findings from an early assessment of the preparedness of primary healthcare facilities in Trinidad and Tobago for COVID-19. Now, this assessment was actually done about 4 or 5 months after the first case was detected in Trinidad and Tobago on March, I think it was the 12th, 2020. As we know globally, our primary healthcare facilities are usually the entry point into the healthcare system for most mild to moderate COVID-19 cases, and Trinidad and Tobago is no exception for this. We also know that we then have to equip our primary healthcare facilities to conduct surveillance and case management. We have to ensure that they are outfitted with the necessary resources to address surge in cases, as well as any associated delivery challenges. Specifically in Trinidad and Tobago, I think it was on April 14, 2020, the Ministry of Health announced that it was going to implement surveillance testing in 14 healthcare centers. Eventually, this was expanded to community testing and surveillance. Currently, all primary healthcare facilities in Trinidad and Tobago are engaged in some level of COVID-19 testing, some level of treatment and/or vaccination. And just to put this within the context of Subteam 4, within the context of COVID-19, it helps generate evidence. This particular research project will help generate evidence on institutional barriers within primary healthcare facilities as well as health systems. So the objective of our project was to assess the capacity of primary healthcare facilities in TNT for the management of COVID-19 in 9 domains. The first one was human resource. We also looked at information, education and communication, surveillance, case management, triage and early recognition, isolation, diagnosis, infection control and prevention, and logistics. In terms of our methods, we receive ethics approval from the Ministry of Health, from the 5 regional health authorities, as well as the University of the West Indies. We use REDCap to conduct an online survey, and we targeted all 114 primary healthcare facilities in TNT. And our respondents were the primary care physicians and district health visitors at these facilities. We used the COVID-19 Health Facility Assessment Tool, and this is a peer-reviewed tool that was developed by the Geneva Center for Education and Research in Humanitarian Aid. Also, the other company that worked on this tool is called Options Consultancy Limited. We had a response rate of about 68%, so 77 of the 114 facilities actually completed the assessment, and most of the facilities were attached to our Southwest Regional Health Authority. In the next few slides, I will present some of the key findings within each of the 9 domains. So in the first domain, which was human resource, we looked at 9 criteria. And what we found is greater than 70% of the primary healthcare facilities actually completed 6 of the 9 criteria. So they had a COVID-19 focal point identified. They assigned roles and responsibility for COVID-19 response team. They conducted training on COVID-19 triage for essential healthcare providers. They had on hand an up-to-date staff list, a daily present staff list, and a protocol was in place to diagnose, isolate, manage, and follow up exposed staff and trace contacts. Areas for improvement within the human resource domain would have been the designation of staff for COVID-19 and non-COVID-19 patients, and training for staff in the safe handling of samples for transfer to reference laboratories. The next domain was information, communication, and education. And again, we assessed 9 criteria. And what we found is that greater than 90% of the facilities that completed the assessment indicated that they had on display information related to hand washing, physical distancing, covering your nose and mouth when coughing or sneezing, the early recognition of symptoms, and telephone number for community COVID-19. Areas for improvement included having on display information for the rational use of PPE for both staff and visitors, and information related to when to attend healthcare facilities versus when to stay at home. In the surveillance domain, and this was the 3rd domain, we looked at 8 criteria, and we found that greater than 75% of the primary healthcare facilities that completed the assessment indicated that they had fully operationalized an algorithm for alert notification and management. They had an official case definition, they had a case investigation form, there was a hotline number for alert, and this number was known by all staff. A surveillance system was in place to collect and receive information on the number of suspected cases within the catchment area. Surveillance data was collected by community health workers. Surveillance data was reported at least twice a week to some district health authority, and this data was tracked and monitored over time. The next domain was triage and early recognition, and we found that greater than 70% of the facilities actually operationalized only 3 of the 5 criteria. The first one was setting up a screening area at a single patient entry point for the facility, ensuring that they had symptom screening questionnaires and appropriate physical distancing was enforced. Areas for improvement would have included temperature measurement at the triage zone and separate waiting rooms for symptomatic patients. And these waiting rooms should have had signage and a control entry. Diagnosis, unfortunately, was one of the domains where performance was a bit lower than the others. And we found that less than 50% of the facilities indicated that they had available sufficient supplies of nasopharyngeal swabs, oropharyngeal swabs, triple packaging boxes for infectious laboratory samples, sufficient viral transport medium, and adequate refrigeration. When we looked at isolation, we looked at 5 different criteria, and we had greater than 70% of the primary healthcare facilities said that they had operationalized a distance of at least 2 meters between patients, and this was enforced. And they also had in place transfer or referral protocol. Areas for improvement included having a designated isolation room for COVID-19 cases, ensuring that there was a visitor restriction, and that is at least 1 asymptomatic relative, and maintaining records, that's name and contacts of staff and visitors entering the COVID-19 rooms. In terms of case management, we assessed 10 criteria, and greater than 70% of the facilities indicated that they had sufficient supply in terms of antipyretics and analgesics. However, areas for improvement included the need to boost supplies in terms of antibiotics, intravenous fluids, pulse oximeters, thermometers, functioning oxygen system, oxygen cylinders, single-use oxygen delivering interfaces, and intravenous cannulas and lines. The infection control and prevention domain had several subdomains that we assessed. So information related to PPE for staff, suspected COVID-19 cases and visitors, staff training, water collection and disposal, water sanitation and hygiene, disinfection and sterilization. This particular domain had over 30 criteria assessed, and I'm not going to be able to present all of it. So I'll present some of the areas for improvement. And I just want to specifically say this information should be interpreted as at that time and not what currently avails at the different primary healthcare facilities. So at that time, we had less than 50% of the primary healthcare facilities indicating that they had sufficient medical masks, long cuff gloves, and long sleeve gowns. Only 4% indicated that they had a fit test kit. 14% indicated that they had laundry receptacles present inside or near each patient room, and only 7% had air dryers. And the last domain we assessed was logistics, and there were 5 criteria in this domain. Greater than 80% of the primary healthcare facilities that completed the assessment indicated that they did have a referral plan in place, which included contact details for patients, and they also had a functioning cell phone or landline. Areas for improvement in this domain included a designated COVID-19 patient transfer vehicle, a laboratory that was identified where samples will be sent, and transport identified for the transportation of samples. So in conclusion, in TNT, within the first 4 to 5 months after the pandemic, the capacity to manage COVID-19 in primary healthcare facilities seemed very, very adequate for some domains. Some domains needed to be strengthened. And in terms of our next steps, there is a need to update this assessment or tool to reflect changes in our existing roles for primary healthcare facilities in terms of testing, treatment, and vaccination. So the roles as at the time in 2020 will be quite different to what is happening in 2022. We also need to update it to include information related to the current caseload or surge in cases and any changes in COVID-19 protocol. We intend to repeat this assessment in 2022. Thanks a lot for your time.
So if everybody can see this, my name is Charlene Goberdan.
Yes, we can see.
And I'll be presenting, okay, great. I'll be presenting today on the formative exploration of the preparedness of community assets to be embedded in primary healthcare. And I'm going to be looking at a comparison of barbershop and place of worship readiness in Guyana. So I'm basically going to be talking about two case studies, talking about the formative phases of these two projects and how we went about gathering information and how it was used. So I'm going to start with a little introduction. So primary health care is just as relevant now as it was 44 years ago when world leaders committed to the Declaration of Alma-Ata. Some would say it's probably even more important now given the public health crisis that we find ourselves in. So primary health care is thought of as the means of achieving universal health coverage, and with the latter being dependent on the success of the former. If you consider the core components of the primary healthcare approach, which is meeting people's needs, people's health needs throughout their lives, addressing the broader determinants of health through multi-sectoral policy and action, and empowering people to take responsibility for their own health, you would find that community and community engagement are inherent to this approach. So these components essentially constitute a whole of society, people-centered approach to healthcare. And community engagement has actually been shown to have numerous benefits and has been shown to have a positive impact on an array of health outcomes. Particularly, it has been shown to improve health service access among disadvantaged populations. Community assets are available resources that promote health and well-being and protect against negative health outcomes. So these would include physical places, social networks, practical skills, and even the interests of the local community members themselves. So faith-based organizations have long been recognized as a powerful community asset in the promotion of health, particularly in underserved communities. And this is due to their physical resources, social capital, and their general prevalence and ease of accessibility. Interventions in faith-based organizations have resulted in positive health outcomes, targeting a variety of issues from HIV/AIDS all the way to mental health. However, most of the literature that you would find on this focus on Christian churches and in more developed contexts. Another community asset that you have is the local barbershop. Whereas faith-based organizations would allow you to reach more women as they are the more regular churchgoers, barbershops offer the opportunity of meeting men and within their community. It's a place they often visit, they network, they even participate in recreation and thoughtful discussions. So leveraging barbershops for health promotion is something with potential, and it's already been shown to, promise has already been shown among marginalized African-American men in the United States, where there's been positive impact on chronic disease management, such as blood pressure control. And there's also evidence to show that there's the feasibility of training barbers in health promotion. If you would look at Guyana's context and Guyana's NCD burden, like many countries within the region, socioeconomic transitioning has resulted in the shifting of disease burden from communicable to non-communicable diseases. Even though we're in the middle of the COVID-19 pandemic, NCDs still remain a burden. NCDs are responsible for 68% of all deaths in Guyana, and 58% of these actually occur in people below the age of 70 years. In 2016, Guyana had both the highest NCD mortality rate and the highest premature NCD mortality rate in the Americas. And you would find that men are disproportionately affected with greater exposure to risk factors and widening disparity between male and female NCD mortality rate. Progress remains slow, and there's increasing challenge to achieve target 3.4 of the Sustainable Development Goals, which is 1/3 reduction in premature NCD mortality by 2030. This brings us to the two case studies that this is based on. So I'll be presenting on parts of the formative phases of these two studies, which are exploring the feasibility of embedding community assets, namely places of worship and barbershops, into the primary healthcare pathway for prevention and control of NCDs in deprived settings. So I will describe the participatory approach that we use to map and gather contextual readiness information, as well as the enablers and constrainers that came out of this work for collaborative partnerships with primary health care. The first study that you have is the congregations taking action against NCD study, or the contact study. And this evaluates the feasibility of training congregants in health promotion and screening, and explores the development of an interface between places of worship and their nearby primary healthcare center. This is currently being done in Jamaica, Dominica, and Guyana. The barbershop study is an extension of contact, and it assesses the preparedness of barbershops for the promotion of men's health. And an intervention from this would see barbers being trained in NCD-related health promotion and screening with oversight from the nearby primary healthcare center. So regions 3 and 5 were selected as possible sites for the contact study. Within these regions, 19 primary healthcare centers were selected. These regions, of course, if you would see in the map here, they're on either side of region 4, which houses the capital city, Georgetown. Regions 3 and 5 are mostly rural with a few semi-urban areas. As I said before, Region 4 is where the capital city of Georgetown is located, and this was selected as the site for the barbershop study. 5 health centers and their associated catchment areas were identified in Region 4 for the barbershop study. And within these catchment areas, 19 villages were randomly sampled. So the aim of this initial phase for both studies was to identify all places of worship and all barbershops and obtain contextual information to generate a sampling frame. Now, due to a lack of secondary data sources, such as complete business registries and lists, ground truthing was used. So this is a method of physically verifying attributes of a community, and it entails canvassing the community to observe any phenomena of interest and to gather relevant information. So printed maps of the regions were obtained, and together with Google Maps, they helped to guide researchers through the communities. For the more rural areas, ground truthing was combined with elements of participatory mapping, which is an interactive approach that draws on local knowledge, enabling participants to create visual and non-visual data to explore social problems, opportunities, or research questions. So this was used specifically in the more rural areas to identify places of worship. And how this was done, we met with staff of neighborhood democratic councils, which are local governing bodies, and they relied on their local knowledge to generate lists of places of worship that they knew that were located within the area. And they were able to collectively map these places onto smaller base maps of the areas. When these were absent, they would create sketches of the area to pinpoint the locations of places of worship. They also provided additional contextual information. Many times they knew persons in the area that they would put us on to go and to get additional information. When we went out to locate these places, we relied heavily on walk-along dialogues and key informants within the community to find even those informal bottom house churches and barbershops that may not, to the eyes, look as though it's a barbershop or a place of worship, and would otherwise not be a part of official lists. So we were also able to find these little places in these very hard to reach areas so that, we could extend the reach of any subsequent intervention. So through the ground truthing and participatory mapping, we were able in all to identify 240 places of worship. And of these, 14 within Region 3 were selected for the intervention, and they were administered a readiness questionnaire. So we had 5 mandirs, 5 mosques, and 4 churches. This is just a satellite map illustrating one of the catchment areas for the Virgin Hope Health Center, and the surrounding places of worship were identified, and the coordinates were identified on Google Maps to create this satellite image. Of the 14 barbershops that were identified, 10 of them agreed to participate in a readiness survey. Now, from these readiness assessments, we were able to collate key information to compare the two in terms of, for example, with geography, most of the places of worship were rural. Well, actually, all of them were. Whereas for the barbershops, there was a mix. You had some urban, some rural. We found that the barbershops were usually independently owned. So the owner or the barber himself owned the barbershop and made all decisions. Whereas places of worship, they had an administrative body responsible for decision making. The barbershop had limited space inside the shops, but they usually had a big yard outside that could possibly facilitate some sort of temporary structure if you wanted to hold health activity. They were also easily accessible. The places of worship, they were of varying sizes, but they all had enough space to facilitate any kind of health-related activities. Plus, because all places of worship had some sort of kitchen facilities, they would allow additional things such as healthy cooking classes. Barbershops, they cater to men of all ages, but some did offer services to women. Ethnicities were evenly distributed. For places of worship, it tended to be mixed, but there was always a predominant, most of them had predominantly female congregants. The only place of worship that had mostly men were the mosques, which we kind of expected. In terms of reach, most barbershops and places of worship, most of the clients and members came from the surrounding area. So there was representation of all 3 religions, and as well for barbershops of varying capacities and price points. And this kind of helped to potentially increase the reach of interventions. The barbershops, they were open most days with longer hours on the weekends to try to reach more people, whereas the places of worship, they open mostly for scheduled services and functions. Congregations, as I said, were comprised more of women, excepting for the mosques. Most places, both barbershops and places of worship, they were well established. They had been in operation for quite a few years. The governance structure of the barbershops simplified decision making, as just the owner had to give permission for anything. Whereas for a place of worship, you needed approval from a board. And sometimes these places of worship, they were affiliated with a parent organization that would also need to give permission for any sort of collaborative work. While the places of worship did have more space and facilities to accommodate health-related activities, the barbershops were equipped with more entertainment devices and such as TVs and digital screens that could facilitate health videos for clients while they're waiting for their appointment. And as a matter of fact, at least half of the barbershops that we spoke to, they had Wi-Fi available for clients. So it opened up a lot of possibilities of additional things that could happen, health-related activities that could happen within the barbershops. Both sets of persons from the places of worship as well as from the barbershops, they thought that health promotion and provision of equipment for basic health measures would be enablers. Barbers also believed that endorsement from local celebrities would be able to encourage men to utilize any intervention that was available at the barbershop. Both sets of persons also appreciated the potential benefits of health promotion activities to their community, As a matter of fact, the barbers themselves were able to recognize the potential benefits to themselves, and they displayed incredible enthusiasm for participation of a subsequent intervention. However, both places of worship and barbershops lacked a history of any collaboration with the formal health system, signaling a potential difficulty in establishing a partnership between the two. One barber in particular was concerned that spending time on health promotion would interfere with his business. Nevertheless, most of them were willing to participate without any monetary compensation. And they agreed that playing health videos and talking to clients during appointments would be the best methods for them to deliver any sort of health information. What we found is that using this participatory approach to leverage local knowledge, it played an important role for us in terms of building trust and relationships with the community. It also helped to inform design of the contact intervention to improve reach and acceptability. However, the one significant limitation is that it is a resource-intensive process because you have to have the manpower to go out there to identify persons and to engage the community. However, by doing this, it could potentially extend the reach of any subsequent interventions. Contextual differences were found to exist both within and between barbershops and places of worship. So caution should be taken when making any generalizations, because especially of the different religious groups that we looked at, there tend to be a lot of differences between them. And that brings me to the end of my presentation. Thank you.
Good morning, and thank you to the conference organizers for allowing us the opportunity to present this topic at the conference today. I represent a group of researchers, primarily from the University of Catalonia and the UNITAR program, and several professors from around the Caribbean. And today we'll be presenting on a governance structural topic known as supranationalism, and whether the Caribbean would have benefited from it considering the challenges, the significant challenges exerted by the COVID-19 pandemic over the last 2 years. To begin, we will discuss an overview of small island developing states, a mention on governance and its relationship with security in regions, the importance of this topic. We will explore specific COVID vulnerabilities, and we will discuss the topic of whether supranationalism would have been beneficial during this time. Finally, we will discuss whether this is a realistic proposition. To begin, small island developing states are commonly found in the Caribbean, Pacific, Atlantic, Indian Ocean, and South China Seas. They actually constitute a distinct United Nations group of 38 member states and 28 non-UN members, but associate members. The aggregate population is thought to be in the vicinity of 65 million, making it less than 1% of the world's population, and therefore perhaps not in the limelight of international relations discussions. However, this group faces unique social, economic, and especially environmental challenges because of the nature of the countries that are represented. Specific to the Caribbean, it is a cluster of islands in a related geographic area. However, the political description is less defined and has evolved from the days of colonialism hundreds of years ago, but certainly with profound effects lasting into today. The Caribbean as an entity has sharp divisions in language, culture, and governance structures as is related to the colonial past of each individual area. There have been Attempts that have been unsuccessful, such as the Federation in 1958 of English-speaking countries. It has been reformed as the CARICOM, which is thought to be independent states combined to pursue a series of objectives as a multilateral association with measured integration. This is as opposed to other supranational entities such as the European Union, which have higher degrees of integration in terms of governance, economies, and political structures. Security of itself is an evolving term, and governance, therefore, is also evolving as security evolves. It was once thought to be synonymous with military, but security actually now integrates elements of diseases, human rights, and even repression. How has COVID-19 affected security? We do know that COVID has debilitated nations with a range of negative health, social, economic, and political consequences. The population-adjusted consequences for small island developing states has been comparable to other nations, but has caused significantly more strain because of the pre-existing vulnerabilities in these island states. The resultant potential threat to the economies, to the politics, to the health of each of these regions is therefore more pronounced. And then by extension, it threatens the security of the small island developing states. There are direct health systems impact, but there are also so many different hidden costs of the economic fallout that we see evolving on a day-to-day basis. The question we ask, therefore, is whether COVID-19 and the security umbrella provided by supranationalism would have been better than the pre-existing multilateral loose integration that is provided at present, or in a grander scale in the Caribbean, no integration when considering English-speaking versus non-English-speaking countries. Would it have allowed a more robust and coordinated response? When speaking about COVID vulnerabilities, we must assess threats and weaknesses. We know that vulnerabilities hamper disaster responses. And looking at the picture on the left, we must note that there is certain inequity on a global scale when it comes to responding to threats. The reality is that certain states start off far beneath where they should be in terms of their disaster preparedness and therefore their disaster response. What we aim for is equity, and therefore giving each state the ability to respond to an obstacle in a way that is meaningful and will allow some sort of resilience and recovery in the face of a disaster. In this case, justice may not be fairly applicable because it's fairly impossible to remove the worldwide threat of COVID-19. But certainly this concept is very applicable when it comes to other elements of COVID-19, such as vaccine distribution. In general, small island developing states have resource limitations that are pronounced. There's therefore less capacitance of internal finance to offset immediate needs. And as we have seen before, COVID-19 provides that double-edged sword of health and socioeconomic challenges. Some of the specific threats and weaknesses. In terms of health, we know that disasters are commonplace when hurricanes ravage the islands on nearly a yearly basis. There's a finite and often small resource pool that is shared amongst some of the islands. There's variable infrastructure and services depending on the political will and political drive in the different states. There's a high burden of existing disease, such as chronic diseases, such as infectious diseases. As we have seen, there are significant supply chain fragilities that have been ruptured during the course of COVID-19. We often see that there is limited data science, and while this is improving worldwide, it is yet to be seen whether the Caribbean and other small island developing states will be able to catch up. Certainly, this is one area where equity can reign supreme. One of the major challenges in the Caribbean is migration of skilled workers to larger economies, leaving to what they perceive as greener pastures from the small island developing states. Socioeconomically, the majority of islands in the Caribbean are constituted of low and middle income countries, dependent on tourism and in one or two instances on hydrocarbons. There was border security challenges during the lockdown, and economy of scale is always less individually when compared to the larger scale. And we will speak about this when we speak about supranationalism. There are foreign exchange limitations, and often this is spoken about in a more social context, but definitely when it comes to the ability to pursue supply chains and to provide economic exchange with trading partners, foreign exchange is definitely something that's very pivotal. And then finally, there is variable political will regarding health, technology, and even external funding. So what are the benefits of supranationalism? How could this have benefited us? So to begin, supranationalism can be defined as sovereign states delegating some of their independent decision-making capacities to a body that stands above the nation state. And to be very clear, schools of thought in international relations are subdivided into those who are primarily nationalistic and others that promote integration. So realists will promote nationalism, whereas others would not. And this definitely goes against the idea of nation state being the supreme entity. This delegates and rescinds some of those capabilities to something that is larger and stands above. The most prominent example is the European Union. And of course, there's potential for strengths and opportunities. And the diagram shows the complex interrelation of the entire EU in terms of the Eurozone, in terms of trade, in terms of health and economic security that it provides. The opportunities in terms of health is that it is possible to pool disaster response mechanisms. And is this applicable to the Caribbean? Very possibly, because we do see EMT programs. We do see the Emergency Management Organization, CEDEMA, which already provides oversight to the Caribbean in terms of disaster response. There is a potential to pool clinical resources. There's a possibility to bargain as a bloc. And we do see some of this in the Eastern Caribbean states. But if there was a supranational state representing more people, representing more persons in the small island developing states, would there have been better access to PPE, to vaccines, to testing equipment, as was seen in the Asian states, in ASEAN? One of the more information technology driven parts of this is pooled data sharing, because as we have seen, information technology is a large and pivotal part of the fight against COVID-19 in terms of tracking, in terms of security, and therefore would pooling of that data within the Caribbean have allowed not just a bubble to travel within the Caribbean, but also to protect the citizens to a higher degree. I put a question mark next to the next point, which is a higher GDP allocation, but definitely it speaks to capacitance for some islands or some members that may have been more able to spare as perhaps exists within the European Union. Would it have benefited other islands that were more vulnerable at that time? The reduction in overhead cost, I think, is something that is not spoken about enough. So for example, social media advocacy for vaccines could have been something that was shared around the Caribbean. The costs or the opportunities socioeconomically, the opportunity to rethink diversification, financial pooling to assist the most vulnerable, national security networks, and building on existing structures, as well as more political and unified buy-in for measures that would have been beneficial. But the strongest part of this discussion is whether this is realistic. We know that it is possible. We know that the University of the West Indies stands very proud within the Caribbean as something of a supranational organization. And we know that from an operational perspective, this would have been beneficial. But national security obviously remains a big challenge requiring multilateral agreements. And data sharing does not require the sacrifice of autonomy of island states. There, of course, are competing interests as tourist destinations, and markets would often cannibalize themselves if they compete against each other. And bargaining blocks such as ASEAN are not supranational. They are integrated in a multinational way, and they achieve very good results. And finally, there is a dichotomy of governance that's evolving in terms of territories and republics. So we see that Barbados, for instance, and congratulations to them, have recently attained the state of republicanism. And therefore, whereas some of the island states may be hinged upon some of their colonial past, others are definitely evolving past that and into the proud national identity that we see today. So the argument, therefore, really supports something that is more in keeping with ASEAN in the Pacific, that requires multilateral agreements, rather than the sacrifice into a supranational state. And on that point, I would like to thank everyone for listening, and for our collaborators from all of the different universities and organizations represented in this presentation. Good morning, and thank you to the conference organizers for allowing us the opportunity to present our topic on the evolving role of pharmacy education in planetary health. In this presentation, we focus on the Caribbean as a small island developing state and the role that pharmacists can potentially have in alleviating planetary health constraints. We represent the Faculty of Medical Sciences, School of Pharmacy in St. Augustine in the Caribbean, and our cohort includes Dr. Sandeep Maraj, Ms. Mala Munilal, Dr. Satish Janki, and myself. So to begin this presentation, we will speak about the scope of the problem at hand. As we know, in the Caribbean, as small island developing states, we are particularly susceptible to the extremes of climate change, including the ocean, bleaching, loss of oxygenation, and the carbon footprinting that is having untold consequences. This is, of course, associated with increased tropical activity in terms of weather, the deadly impact of heat and the environment, and the associated impacts that are known to be downstream. The rationale behind this presentation is that we know planetary health is a growing concern as every day goes by. We know that this growing concern is linked with negative human behaviors. We also know that human behaviors can be modified by education, but this education is predicated by having a mentor who is trusted within that society. We also know that trust is placed in pharmacists because they are accessible and they are educated, and they are often perhaps the most personable individuals within the healthcare system. And this accessibility, this combination of the correct elements, imply that this can be a planet-wide solution in this problem. But the real question is, can we train pharmacists to become planetary health advocates? To answer this question, we must look at a marketing expression known as market penetration. In the broadest sense of the word, what we do is target broadly. We message in a way that is non-specific, but yet still very impactful. What we are looking at in this presentation is targeting in a more narrow manner that is concentrated, targeted at a particular niche, and therefore can achieve some elements of micro-marketing. The existing marketing looks like this. Go green before we go blue. Definitely a poignant message, as we see the gentleman painting the oceans to envelop the land masses that are around them, and certainly spelling disaster for the entire planet. In this message, where pharmacists can target individuals coming into their community businesses or their community hospitals. We know that the pharmacist may be in pole position to identify persons that they can educate and therefore transmit a message to a particular niche as opposed to the broad market, and therefore encourage persons to change their behaviors. The objective and method of this presentation and of this paper that we have presented is that we utilized a rapid review of Medline, EMBase, and Google Scholar, where the terms planetary health, environmental health, pharmacy, and environmental impact were all searched in conjunction. Two reviewers independently screened the result and abstracted data from the studies. Thereafter, a narrative summary was developed. In essence, an analysis of operational pharmacy practice that can potentially improve planetary health outcomes to identify key areas that can be used to sensitize students to the challenges and opportunities to the improvement of planetary health. Some of the results. The first form of sensitization that students can be educated on is planetary diets. The Eat Lancet Commission's planetary diet restricts meat, dairy, and starchy vegetables consumed in the population. Pharmacist platform, accessibility, and status of trust in communities allow them to become advocates for lifestyle change. And in fact, many patients visit pharmacists seeking such advice. Pharmacy education, therefore, must develop a curriculum and continue to develop that curriculum to allow practitioners to be versed in these guidelines as outlined in Eat Lancet, but must be able to enact them in a way that is meaningful, succinct, and applicable to the population being educated. This advocacy is certainly achievable. Secondly, in terms of plastics consumption, we know that global plastics production has reached approximately 360,000 tons in 2018. Pharmacists can champion reduction by changing customer behavior from single use and by promoting recycling, by having bins available within their premises and by encouraging people to do the same in their households. Also, we know that pharmacists often engage in industrial practices and therefore will eventually attain some element of permanency and of status, and therefore they will have the status in the future to hold a position where they can disrupt practice standards and improve packaging to things that are recyclable. Pharmacy education, therefore, must develop a curriculum that allows practitioners to be knowledgeable about the harmful effects of plastics and to the potential for recycling and reuse within the society. Finally, medication disposal. We know that improper drug disposal at a household level leads to trace elements entering water tables, which cannot be removed by existing filtration systems, and therefore can have harmful effects not just on humans, but also on animals and on the environment. Pharmacists should engage patients in education about the use and appropriate disposal of expired medication. Pharmacist education, therefore, must develop a curriculum that allows practitioners to be effective in counseling and communication with patients in a manner that is sensitized to disposal and the potential harmful effects. Everyone must have a role. That role must outline that climate change is real. It is very unfortunate that in 2022, this argument must still be had. But we do know that the effect of climate change is real, and we do know that the effect of climate change in small island developing states can have untold disastrous effects. Therefore, we must have a plan. And a part of that plan must be education, advocacy, mentorship, and treatment. That plan must include all stakeholders at all levels, and our presentation today certainly provides the impetus so that pharmacists can achieve their role and achieve results. With that said, I thank you for your time, and I acknowledge the institutions to which we are all affiliated, and we'll be happy to take your questions.